Management of implantable cardioverter defibrillators, or ICDs, at end of life. According to the Heart Rhythm Society, it is estimated that in the United States, 250 to 300,000 people suffer a sudden cardiac arrest or sudden cardiac death per year. To date, the best modality of primary and secondary prevention of an arrhythmic sudden cardiac death is the implantation of an internal cardioverter defibrillator, or an ICD. In February of 1980, the first internal cardioverter defibrillator was implanted in a patient at Johns Hopkins University by the inventor himself, Dr. Michel Morawski. Dr. Morawski developed the ICD years prior after witnessing the sudden death of his mentor and friend. The ICD was a novel concept in that it was surgically implanted in the thorax or abdomen of the patient with leads that attached to both the myocardium as well as the generator. Should the ICD recipient experience a spontaneous arrhythmia that could otherwise culminate in sudden death, the device would serve to identify the arrhythmia and treat it with a high-energy countershock. This advance forever changed the cardiology landscape. ICDs and other advancements in cardiac care have extended the life expectancy of cardiac patients, and many ICD patients are living long enough to develop non-cardiac terminal illnesses. In addition, while the ICD can abort sudden cardiac death, it does not prevent progression of coronary artery disease or congestive heart failure or cardiomyopathy. Despite advances in medicine, there will come a time in all patients' lives when death is inevitable. The notion of a painful and generally futile shock at the end of a person's life is often inappropriate, as passing with a fatal arrhythmia may be a welcome alternative to the active dying process. In reality, ICDs can easily be disabled through non-invasive programming to eliminate the threat of unwanted therapies, though ICD deactivation discussions do not happen frequently or with any regularity. In 2005, nurse practitioner Deborah Grassman of Florida penned a letter to the editor of the American Journal of Hospice and Palliative Medicine, reporting a disturbing experience she had recently had with one of her patients. She wrote, "We had a patient who went home with hospice. The defibrillator was never turned off. As a result, the wife reported that the patient died in her arms while the defibrillator jolted him 33 times before the battery finally ran down. She stated that the defibrillator got so hot that it burned right through his skin. Needless to say, this greatly distressed his wife. She has had difficulty getting this memory of her last moments with her husband out of her mind." In the United States, more than 140,000 ICDs were implanted in 2009 alone. Although ICDs reduce mortality related to sudden cardiac death, recipients remain vulnerable to death from other causes. Despite the effectiveness of these heart rhythm devices in treating arrhythmias, there is a 5 to 20% annual mortality rate for device recipients. While there are no formal practice protocols that address ICD deactivation, the American College of Cardiology, the American Heart Association, and the Heart Rhythm Society all recommend that patient education begin at the time of implant and should be ongoing. Physicians admit that it is important to discuss, but rarely do so, due to discomfort with the subject and a reticence to take away hope, as reported by Goldstein, Mehta, Teitelbaum, Bradley, and Morrison in 2007. Patients are therefore denied information which inhibits their ability to make informed decisions and engage in a peaceful death. The ICD can be disabled in the event of a terminal illness to prevent the patient from receiving unwanted ICD shocks in the waning days and moments of life. Unfortunately, this is an option that is not often discussed or implemented to ease a client's transition to death. In a study performed by Goldstein, Lampert, Bradley, Lynn, and Krumholz in 2004, of 100 decedents of patients with ICDs who died of any cause, 27% reported that their family member received a shock in their last month of life, and 8% reported a shock in the last minutes of life. The study by Kitch Westerdahl et al., published in Circulation last year, provided a definitive answer to the question of ICD therapies at end of life. They set out to reach beyond the grave and performed post-mortem device interrogations. In addition to these interrogations, they performed a retrospective chart review on the same subject. They looked at a series of 130 patients who died between 2003 and 2010. Amongst these, 35% had ventricular arrhythmias in the last hour before death, and 31% received a shock in their last 24 hours, including many with arrhythmia storms, some of which received over 10 shocks in their final hours. There is a tremendous opportunity to improve the knowledge base of the medical community as a whole to impact this issue. Kelly and colleagues performed 2 separate studies in this regard in 2009 and 2008. They reported that 10% of physicians thought ICD shocks were not particularly distressing to terminally ill patients and their families, and 14% of the physicians were uncertain. They also reported that almost 10% of physicians reported lack of sufficient knowledge of ICD functions and deactivation options, and 6% said they had not considered discussion of ICD deactivation with terminally ill patients. In a separate study, Shirazi and colleagues discovered that almost 50% of providers surveyed were either misinformed or confused about the legality of deactivation. The literature regarding patient experience with regard to choosing to deactivate an ICD in the face of a terminal illness is confusing at best. Both the Heart Rhythm Society and the European Heart Rhythm Association have addressed the importance of discussing the option of ICD deactivation at end of life, though there are few studies looking at whether this is actually happening. Pedersen interviewed 440 ICD patients in the Netherlands and reported that 68% of respondents were aware of the fact that their ICD could be disabled, 95% believed it was important to inform patients of the possibility, and 84% actually indicated a choice for or against deactivation. On the other hand, a recent U.S. study looked at 54 ICD patients, and only 3% recalled receiving information regarding the possibility of ICD deactivation during implant consent, and only 38% became aware of the option at a later date. Even if recipients are made aware of the option to disable their ICDs, the literature regarding what they will actually do is also contradictory. Goldstein and colleagues conducted a focus group with 15 ICD patients and found that, despite expressing a great deal of anxiety about receiving shocks, none was willing to discuss the possibility of device deactivation at end of life. In a subsequent U.S. study, only 42% of patients were in favor of deactivation, though 28% said it would depend on the situation. In 2010, Stewart and colleagues surveyed symptomatic heart failure patients and found that many ICD recipients actually feared turning off their device. Provider perspective. In a large European study published in 2010, 83% of cardiologists reported that multiple ICD shocks in dying patients was considered a primary indication for ICD deactivation. 80% of the respondents said that the patient should make the decision about deactivation. And although ICD deactivation was viewed as reasonable by the majority, it was performed in only 6% of the cases. There appear to be many barriers on the part of the provider in terms of initiating the discussion and ongoing dialogue. Hopman and colleagues interviewed 734 cardiologists, internists, and family practitioners, as well as geriatricians, and noted that ongoing discussions of ICD deactivation with patients or family members were uncommon. Only 25% of internists and family practitioners and 40% of geriatricians reported having these discussions, though 75% of cardiologists did discuss device deactivation at least once. In another study of European electrophysiologists and cardiologists, 85% of respondents reported discussing deactivation, though only 4% of respondents routinely discussed deactivation at the time of implantation. The literature does, however, suggest that providers recognize the importance of such discussion and the appropriateness of deactivation, but there seems to be a gap between belief and action. Goldstein and colleagues found that although many physicians said that they believed device deactivation discussions should be included in advanced care planning, they also admitted that they rarely do so. Shirazi and colleagues found that 22% of physicians interviewed would feel uncomfortable deactivating an ICD for a terminally ill patient, although 59% of those patients knew that an ICD shock would in fact be painful. There are, however, some positive trends in the ICD community. An example of an effective multidisciplinary program was reported by Lewis et al. In 2006. The authors retrospectively reviewed medical records of all deceased patients who had been followed in a device clinic which had a procedure in place to identify ICD patients with terminal illness and to initiate discussion of deactivation of ICD shock therapy. At each visit, an advanced practice nurse and EP, or electrophysiologist, evaluated the patient, and those with terminal diagnoses received information regarding the option to deactivate shock therapy. These discussions were timed in conjunction with the primary care physician's discussion of end-of-life care. Patients who opted for comfort care only had shock therapy turned off within 24 hours. 100% of patients identified with a terminal illness had their shock therapy turned off before death as a result of this intervention. Use of this comfort care approach allowed ICDs to be turned off in response to the patient's goals of therapy and patient's wishes to maximize quality of life. Further testament to the benefit of enhancing education in this regard is apparent in research reported by Mueller and Associates. In 2008, they used a web-based survey of Heart Rhythm Society members and reported that device deactivation in terminally ill patients was common. 86.8% reported receiving requests for ICD deactivation, 95.4% reported ordering device deactivation, and 92.4% reported having personally deactivated a device. On a side note, the difference in this study may be attributed to the fact that the respondents are members of the Heart Rhythm Society and thus exposed to education offered by the society in this regard. In conclusion, the option of disabling an ICD at end of life should be discussed early and often. Patients should be afforded this opportunity when they are not under acute stress, as is often the case during routine office follow-ups, and should have time to contemplate this issue and discuss concerns and questions either during that visit or at a later date. This approach encourages the patient to become an active participant in his or her health care and assume a prominent role in the healthcare team. Nurse practitioners of all specialties are in a position to initiate or continue this discussion, encourage patients to have these discussions with all of their providers, and refer patients to their cardiology or electrophysiology colleagues for further clarification. Thank you very much for your participation. Please proceed to the post-test at the conclusion of the presentation.